Thank you. Thank you for your wonderful questions. It's been wonderful to be here. You can't imagine how much energy we get from being with all of you. We always really make time to be in presentations where we can share with patients our own feelings. We try to do that within our own practice as well, but as you know, it's always more limited. So here is a perfect place. Because we're a smaller group, I would suggest that if you have questions on what I say, you would raise your hands to just say, can you clarify that? Because at times we speak with language that is medical, and I don't want to do that. And there's a lot of technicality, particularly in this talk. So I would prefer that you would ask me the questions and say, oh, wait a minute here, you're kind of going on top of my head, and this is not what I do. And a lot of people are on top of my head as well. So don't feel ashamed for that. We all have something else that we don't know anything about. So my main goal here is to tell you about the different corticobasal degeneration presentations. Tell you that corticobasal syndrome is the original presentation. That's how it was originally described. But then go in more detail on what happens when we make diagnosis that in retrospect perhaps we are learning something, but we don't have enough data to really modify things completely, although we have used all our knowledge to develop new criteria for corticobasal degeneration. I'm putting it all here, but in truth, I'm not supposed to, because it's not published. It's to be published in neurology soon, but they don't allow us to really share in publications. It's not a publication, this, it's just sharing information, but still, let's keep it within. The other thing is, as well, what is it that we're doing in research, and go more in detail on our own limitations, on why research is not advancing faster, that I know is what all of you want. So, as I said, corticobasal degeneration has multiple phases. And if I'm in the middle of all of you, I can also sit. Am I? Yes, I am. I knew that. So let me sit there, and then I will not be moving. All right. So one of this presentation is the corticobasal syndrome. Another one is the what we call primary progressive aphasia. That means that there is a primary or there is a progressive difficulty in speaking, and this has to do not with how we pronounce, but mostly on the wording, on having what we call a non-fluent aphasia, and that's a technical term for sure. The non-fluent aphasia means that we try to speak with less words, or it's not that we try, we cannot have any other choice than speaking with less words because words don't come to mind. We all, as we age, have that problem, and we try to overcome it. And we do what we call circumlocutions. That is, we don't know how to say spoon, and we say that's stuff. Or we may say something that we use to have our soup or something like that, something that gives you the sense, but the word doesn't come to mind. So that's kind of a difficulty with expressing ourselves. Not a problem with memory per se, a problem with language, the real language content. The other one is, as we mentioned before, the frontal behavioral problems of dementia. That is, the difficulty planning ahead, the difficulty thinking properly on consequences of what we do. We may act more impulsively. We may act with less care compared to what we used to do before. And we may have more difficulty doing multiple things together. That in some ways, as we age, we all do. This is an exaggeration of aging in some ways. It is also the PSP presentation, the one with falls, the one that is with eye movement problems, and what some people call the symmetric corticobasal degeneration, because at times it doesn't have the eye movement problems. So the classical presentation again is someone, and this would be the typical presentation, and I'm gonna let you listen to someone, I think I'm not sure if it's the same patient or someone else, that really explains well all the symptoms. So usually it is basically in upper extremities, unclear why, but it's usually one extremity, and it's like that arm that doesn't do the things well, and it doesn't cooperate in the right way, and so things become more difficult to be done. And this lack of cooperation, dexterity, know-how doing things, that is actually the know-how is really what is lost, doesn't respond to medication. It doesn't respond to that kind of medication, but just kind of going ahead of myself, rehab helps. That's another story. So that's why we call the idiomotor apraxia or apraxia per se. The jerks that you heard, yes?
Will it eventually go on the other side of your hand?
Yes. So the disease is usually unilateral and spreads usually within the same side and then to the other side.
And approximately how long after that?
That's a very difficult question to answer. We don't have the knowledge of.
Repeat the question.
Oh, I'm sorry. The question was, how long does it take to go from one side to the other? And that we don't know enough as to really have a timeline on how long does it take. But certainly it is slow. And I always say to my patients, things don't happen from one day to another. When they do, you have something else. So things happen in a slow way, and it's always in retrospect. I used to be able to do this, but I'm not sure exactly when, over the past few months. And if we push, someone says, well, maybe over the past 3 months or 4 months. And, there's never, on September 15th, I noted that my hand couldn't do this. That doesn't happen in these diseases. Is slowly progressive, and that is also part of the difficulties in reconstruct a very good timeline. But we get the timeline. We know that it doesn't happen immediately in the arm, in the leg, and in the other side, and things like that, because if they would, it would be another disease.
Is there something you can do to slow it down?
We'll get to that. And the question was, can we have things to slow down the progression? That's treatment. We'll get there. So,
Idiomotor apraxia, is this a way to describe it? It's like the loss of body geography? They don't know which arm they're going to move?
no, it is the know how to do something. For example, you automatically fold things when you finish washing your clothes, right? And you just do it automatically. You don't even think, right, in how you do that. Well, you lost that capacity of doing it with one limb. So when you're trying to fold, you can't really do it right. And so you're struggling, and you realize that you're struggling, and you know what you want to do, but it doesn't come, the movement, it's like many people describe it as my hand doesn't follow or doesn't obey me, doesn't want to do what I want to do. And that's a very good description of what the feeling is. You want to do something, you know what the outcome should be, but you cannot get there. The other one is the feeling that your limb is not your limb. And how is that feeling? The feeling of alienness, as if something that is there aside to you, you don't recognize as yours. As if you see it as a hand, but not as yours. It's not the feeling that is your own hand. That's why this is rare. It's not as frequent as people think it is. The feeling that your arm is not your own arm, as that patient said, that when you put it in front of you, it's not there. When we put it in the back and you said, which hand is it? And you put, the patient hand and your own hand, and the patient says, I don't know whose hand is that. That is not frequent, but that happens. Have patients that report, one of my patients was a teacher, and she reported that when she was giving a class, she felt that her hand was moving and touching herself, and she felt completely ashamed because she said, what's going on with his hand? She couldn't stop it. Another patient of mine told me that he was talking with a friend of his, and suddenly he saw that his hand was going into his friend's pocket. And he said, oh my God, it's good that this is my friend's pocket and not someone else that doesn't know me. But that is unfortunately the things that happen. So it is really the feeling of alienness. The hand does things on its own that I cannot control.
And did you say earlier, Dr. Litvan, that the myoclonus can occur in the alien limb?
Yes, yes. So the question was, does the myoclonus occur in the alien limb? And yes, all these symptoms that I'm describing occur in the same limb that the symptoms start. So we're talking about feeling that you're slow with the movements, that your hand may get a dystonic posture, that basically what it means is like it gets into a fixed position, although it's not completely fixed initially, but let's say that you're walking and you're walking with your hand like this, something that is not usual. Or the hand has a different position with the fingers that is not usual. So that happens. And it may happen that prior to that, the motor symptoms of jerking, or prior to that, the difficulties with folding or knowing the know-how occur. And then eventually it may happen that you also feel that your limb is not your limb. As I said, we don't need all these symptoms to occur, and some of them are very, very infrequent. Alien limb is one of those that is completely infrequent. Yes?
You said that at first you get problems in your hands, but when do you get problems in your legs?
Well, the disease spreads and usually starts in an upper limb, and then it goes to the lower limb. Usually the symptoms in the lower limb are not the first, but at times it does occur that they are the first ones, and that's why falls occur first. When falls occur first is because that leg is not knowing the know-how. So when you're trying to move your left leg, if that's the affected one, you have difficulties because you lost your know-how in your legs. Similarly, when it goes from the upper hand to the lower limb, then you may have those problems as well. This patient has clearly, he was a policeman, and he said, and you can see that there is a clear asymmetry, and he has both the dystonic hand here, the hand in that position, as well as, starting with the left, I'm asking him to move the left, and then he's moving the right, but he has it already contracted, because initially is the abnormal positioning, but eventually it gets contracted. And those little jerks that you see are the myoclonus. So here what you're seeing is the myoclonus and the dystonia. So then I'm going to show you the next patient, that is the one that I showed you before, because she is, I think, the most clear person telling the story. And you're going to notice as well that her speech is very slow and deliberate. And that is also another problem that occurs. Speech may become very deliberate. But then I want to explain the other symptoms.
My main problem is my right hand and arm that I can't use.
When did that start?
I think about 3 years ago.
She cannot use the hand.
Well, I went to an arthritis doctor for my writing. It started with my writing. I was losing control of the writing. Then it was hard for me to cut my food. See, I'm right-handed, and it was hard for me to cut my food and to eat with my right hand. The hand started to jump. Not so much shaking as jumping, and I couldn't control it.
Would you see that at times the hand would be moving on its own and you would realize that it was
Yes,
moving?
especially at night in bed. I would wake up and the hand would be up.
That's what we call levitation.
You feel at times that your own arm was not your own arm?
The right arm, yes.
Do you have any feeling that you're slower than you used to be?
Oh, very much slower, yes. It's hard for me to get in and out of a car.
You feel unstable?
Yes.
So she has some difficulties on the left that are minimal, and you can see that the major difficulties are on the right. And she also has what we call sensory neglect. That is, when you show two stimuli, she sees only one side, but she can see well both sides if they are separate. She has an increased tone. This is the maneuver that Robin was telling you, and you can see that the myoclonus is making her move her hand in an irregular way. She does it so much better on the left. And here is
The right arm, the left arm, the left arm.
so I'm touching both.
The left.
Again, I'm touching both, and she feels only on the left. But initially, she could feel both. And she's still walking very well.
Whatever I do with my right hand, the left hand mimics whatever the right hand does. And then at the same time, the left hand goes against whatever I'm doing. For instance, if I try to cut something, the left hand is continuously shaking and out of control.
Okay. Is just the shaking, or is there anything else more active that goes against what you are trying to do? For example, you were giving me an example of whenever you were trying to put your bra. What is the hand doing against that?
Oh, well,
It's just a shaking?
yes, it's just shaking. And for instance, I have a bad habit of demonstrating. I'm sorry.
I think I'm going to move on. All right. So you saw those symptoms that were unilateral. Initially was Brad Bobet from the Mayo Clinic in Rochester in 1999 that he showed that people that have this syndrome, this corticobasal syndrome that I just explained in detail, only 50% of them had actually corticobasal degeneration. And you can see that by then already 17% had PSP, 11% were actually Alzheimer's when they had the autopsy findings, 3 had Creutzfeldt-Jakob disease, that is like the mad cow disease. And that is actually because the disease really went very fast and nobody realized it. This disease doesn't go in 1 year. So if things go in 1 year, there's something else going on. There were other diseases like frontotemporal dementia as well. Here is a patient of mine who had come to NIH, and at the time we thought that he had corticobasal degeneration and he had a corticobasal syndrome. But actually, in the autopsy, he had Alzheimer's disease. And you can see that one of his symptoms, and he said that he started with difficulty playing tennis. And when he was playing tennis, actually, he couldn't see the balls that were coming to the right side. And then you can see this very well in when he's trying to do a watch, he just neglects completely all, I'm sorry, it was the left, on the left side of the clock, all the numbers. And in fact, that he developed as well dystonia, he developed all the same symptoms, and you can see that he had even the myoclonus, pretty much everything that is corticobasal degeneration. In fact, even the MRI of the brain was asymmetric. You can see that there is a very much difference between one side and the other. One is much more affected than the other. You can see that here, right? This is part of the brain. These are parts of the cerebral spinal fluid. So these black things here is not brain. And you can see that here there is much black space than here. And this corresponds to the right side, and his left side was the one affected the most. So even the brain scan was exactly what we predicted for corticobasal degeneration. This was the posterior part, and yes, you're right. The involvement of the parietal areas is what leads to the neglect. So the posterior areas, and this is usually what happens. The corticobasal syndrome at times is what we call the focal presentation of Alzheimer's disease. So it is Alzheimer's, but it's not the garden variety of Alzheimer's that is more symmetric, and it doesn't have the motor problems. It doesn't have all these problems that I'm referring to, the neglect, the alien limb, the dystonia, none of that. When we look at the brain, we saw that there was the same asymmetry, that there were many less or cells in one side and the others, and the tau, that is the lesions that we were talking about that are in these cells in the brain, were more in one side than in the other. And as I said, this is exactly what is being shown nowadays. So this is corticobasal degeneration, one of the presentations of corticobasal syndrome, one of the presentation of corticobasal degeneration. And another one is a protein that doesn't have anything to do with tau. This is a different protein, TDP43, more recently discovered, that happens more in frontotemporal dementias, but it can also be the underlying protein that clutters the cells. And so that's one of the problems. If it would be all tau, we would be in better shape, but there are other proteins like the beta amyloid that occurs also in Alzheimer's, or this other one. So now I'm going to give you the other side of the coin. We said corticobasal syndrome is one presentation of corticobasal degeneration. Now I'm going to go to the corticobasal degeneration side. So we have difficulties with this presentation of the disease, but then the disease presents in multiple other ways. What are the other ways? Well, I show you that, and I told you before, the corticobasal degeneration diagnosis was made because it was a corticobasal syndrome. But 6 people were diagnosed as having atypical Parkinson's disease. 2 as PSP, 6 as dementia, Alzheimer's disease, 4 as progressive primary aphasia out of 32 people. So you can see that at the end, even pre-mortem, before the patient passed away, 50% only of the patient were able to be diagnosed accurately, and they did have corticobasal degeneration, but 7 were diagnosed as PSP, and there were 4 that continued to be diagnosed as having the primary progressive aphasia. I showed you this before. This is, in fact, cases that were diagnosed as corticobasal degeneration and presented. Almost 48% actually of the corticobasal degeneration presented as PSP. A quarter as corticobasal syndrome. And from those that had these different presentations, you have the progressive aphasia, but it's a few number. But again, these are the numbers from the Mayo Clinic, and it's just one of the series. But in general, the series are not extremely different. So we talked about the dementia, but at times that dementia, when it's frontotemporal, it goes with Parkinsonism and is bilateral, and that's what is called the symmetric corticobasal degeneration. And at times they have signs that are pyramidal signs, that are motor signs that do occur when we are born, that are symptoms or signs that we see but really don't transmit into symptoms. This is one of our patients.
Your name and today's date.
Well, maybe I shouldn't do that. For HIPAA things, I should not do that. Let me go back and get into a review we just recently did of all the literature. We look at all the publications that existed, and there were in total 209 patients that had autopsy confirmed corticobasal degeneration, and then we look at all those in which there were description of the symptoms, and we got that at presentation. For example, the motor symptoms were, and you can see that it's not 209, the denominator is 114. That means that we lost already 100 people that we don't have data from. But from those that we had, we did the percentages. So it's 65 out of the 114 that we knew that described the symptoms. 57% reported stiffness. 48% reported slowness. 41% said postural instability. A third had falls. A third had problems with walking. Almost a little bit more than a quarter had problems with either feeling stiff axially. A fifth had tremors. Approximately of 20% as well had the dystonia, and a little bit less had the jerking in the myoclonus. That's a presentation, and you can see that the symptoms progress, some more than others. And then similarly, we look in the same cases, we look at the cognition, and again, we don't have all the symptoms, but approximately 50% at presentation already were having cognitive problems. Behavioral changes were the most because, as I said, the apathy is very significant. The language problem is important. The problem with the know-how of the movement is a problem, as well as depression. This corticobasal degeneration, different than PSP, depression is more important. Depression is organic here. It is part of the illness. And you can see that alien limb occur in 22%, although everybody talks about it, is not as frequent. So if we're going to wait for that symptom to occur, we will misdiagnose most of the patients. And there were other problems, and other problems are the eye problems. Some patients did have problems with the eyes, even a third of them. Some of them as the same problems that we talked about with the saccades, but here the saccades are different. We talked about these rapid movements that occur between two stimuli, and you can see the rapid movement normally. We talked about the slowness here, moving the eyes, but the patients, what they have is difficulty initiating the movement. Oh, I'm sorry. Maybe I should wait. Or I should take that one out. Okay. So here you're going to see that.
Are you doing it?
So I'm asking him to move to the right, and
I would like you to look to the left.
he did the move. When he did it fast, but he has difficulty starting the movement.
All the way up.
You can see that he's doing the movement because his front is wrinkled, but his eyes don't go up. So that he's making the effort, but he cannot do it voluntarily. But on the other hand, you can see that he follows beautifully up and down the pen. So this is different than what happens in PSP. He actually can have the oculomotor movements, and they're fast when they occur. But the difficulty is in initiating the movement. And that's what we call oculomotor apraxia. So as the apraxia of the hand, the know-how, there is an apraxia of the swallow, there is an apraxia of the speech, there is an apraxia of the gait, as you lost the ability to know how to do something, and that's difficult. Is horizontal as well, and that's a very good observation. In fact, that is what also helps, is horizontal and vertical. That is different than in PSP, that is just vertical. So after reviewing the literature, and actually before we met all these experts in the field that knew about all these disorders, we got together, we brainstormed, how can we make this better? Because we all realize that if we don't have a good diagnosis, we cannot do research. And if we cannot do research, we cannot advance on how the disease, why the disease happens, what is the problem with the disease, and how we can treat it. So we certainly need to get to that diagnosis in life as soon as possible. So we came up with ways of diagnosing it differently. I have to say that this is an effort that needs to be what we call validated, because we can propose based on what we know today. But things change, knowledge changes as time passes by. So what we need to do now is to look ahead and prospectively validate this. That is, diagnose using this criteria, and then look when someone passes away, what was the diagnosis, and see if what we did was right. So we are supposed to increase our accuracy early on or whenever it is, and make the diagnosis more correct. So we use, and you don't have to really learn any of this because it's not the point. The point is to show you that we divide it in two categories, possible and probable, possible being less accurate, and probable being more accurate. And we put as corticobasal syndrome as one of the categories, the frontotemporal dementia as another one, the language problem, the primary progressive as another one. And we try to include some of the features of the corticobasal syndrome within these presentations to try to see if that helps making the diagnosis. We don't know, The truth is, this is the best we can do today. So we said if someone presents with the stiffness or the slowness and the dystonia or the jerking plus, so two of those three plus two of the following, the apraxia, the cortical sensory deficit, the alien limb, then we can say if those two occur, 2 and 2, then that's probable. We can still make mistakes, right? But we're hopefully closer. And we said possible and we open it up. Here we did not accept genetics. If there is family history, that's not the disease. In the other one, we were looser because we want to learn more. So we want to diagnose more cases, but being perhaps less specific. That is what happens now. We diagnose a lot of people, but they were not very accurate. What we're trying with the probable is to diagnose less, but being more accurate, because those probable are the ones we want in research, more than the possibles. I don't know if that makes sense. We came up with the frontal behavioral problems, that is the executive problems difficulties with personality changes, or visual spatial problems. So 2 of the 3 are the frontotemporal degeneration. And then we came up with the PSP syndrome, but I was very concerned with that because we are very good at diagnosing PSP, and so I thought now we're going to have trouble even diagnosing. We're improving one and we're going to make the other one worse. So what we did is to make this as possible, and we were not so strict. So this is not exactly as the diagnosis we have for PSP, because we don't want to, make a mess. But certainly, as I said before, the important part here is that both PSP and CBD have the same protein that agglutinates in the cell. So if we find a treatment to slow disease progression, in both we'll do the same. Yes, there are some questions there.
Could you explain a little bit more about personality change? Is it in the negative or the positive?
So the question was, can I explain personality changes? Is that in the negative or the positive? That's obviously a subjective question. But it's true that people that may be more aggressive before may get more mellow, and that's a positive, I guess. Instead of being pushy, now you're mellow. But it could be the opposite. Somebody that was more mellow may become a little bit more irritable, more frustrated more easily, and things that people that were not really feeling any pressure, now they're upset and react more with more frustration to the inability of doing things. Because one of the important things about these diseases is that this is not Alzheimer's disease. As you all know, the brain is still there, as many patients say. So it's not that you don't know. You can't say, well, he doesn't understand what I'm talking about. You know that the person assigned to you knows well what you're talking about. It's not that the problem. The problem are the symptoms, but they're very different than Alzheimer's disease that may not understand. Here, understanding is perfect. Does that clarify a little?
Exactly. Yeah, my thinking is very sharp.
Yes. I don't know. Were you the one? Yes.
The focus so far has been diagnosis, accurate diagnosis, literature review of cases. I have frustration because I want to know what can we do.
So her question is very important. We've been stressing diagnosis and we haven't talked about how can we treat this disease. But I'll tell you about that in a minute. But I have to say, and she says that she's frustrated. I am too. I am too. Because you can't imagine how much we feel for our patients, how frustrating it is not to have a solution and not be able to say, here you are, you're walking, you're doing great, everything is back to normal. When we do that, we feel, it's an achievement for all of us, the patient, the family, and us. It's hard when it isn't, and we don't lose our hope. I don't. And that's what I hope you don't lose it either, because hope is what maintains us moving forward, and we know there is research that is trying to help us move forward. But I'm going to go faster because I think I'm losing time, and I want to get to the important part, that is, what are the other things that we're doing? But I have to admit that I am a strong believer that without an accurate diagnosis, we cannot advance the field. There's no way around it. I mean, this is like trying to improve something that you cannot even say what it is. How can you? So just to say that how someone presents important because survival is different. And the MRI, I already mentioned that is limited, and we mentioned as well that there are other findings in Europe. So summarizing, we don't have the biological markers. That's what we're after. So that's our major research nowadays. How can we get to find something in the blood, something in the skin, something in the spinal fluid, something in the saliva, something in the MRI that would help us really come up with a diagnosis? It would be wonderful if we could have imaging that would allow us to know where tau is deposited. Then we would know, you have tau, you have alpha-synuclein, now we're ready. Let's go for the treatment. We don't have that. But the day we'll have, I believe, is going to be a major advance in the field.
I think Dr. Boxer has a grant right now for biomarkers for CBD.
That's correct, and we're part of that as well. So we're working together with that idea. We're really trying to work on searching for the biological markers, and that is very good. And I thank you, all of you, for participating in research. You are doing major things to other people as well. So let me go into what we know about epidemiology. Zip. Nothing. We don't know how many people have this disease. We estimate, but we estimate based on what? On people that had Corticobasal syndrome, but we already know that half of those at least don't have the disease, and many others have some other presentations. So all these estimations are nothing of value. So we don't even know how many people have the disease. Something to work on. We know where the lesions are, but that again explains the behaviors. We know as well what are the lesions in the brain that allow us to make the diagnosis. These tau aggregates here in the neurons, these astrocytic plaques. We need to know more than that. Why do they occur? Why is tau relevant? It binds to the microtubules. It usually is there allowing those tubules to exist, but then in these disorders, they are collecting as aggregates, and they make the cell die. And we know some of the conditions that make it die, but we need to know why. So we need to know the genetics, we need to know what are the process. So there are some diseases that have frontotemporal dementia and have a mutation, and this mutation can present at times with PSP in some families, and in some other families as Corticobasal syndrome. Interestingly, right? Because that means that there is another gene that is making that switch, or there is some environmental factor that is making the same gene presenting differently in two different families. So we're learning from that. We're learning as well why these families do have these aggregations. But as I said before, corticobasal degeneration is not hereditary. There are no mutations that really would explain what you have. We do know that tau has some abnormalities and it collects in different gene variations that we call polymorphisms, and that they segregate together into different forms that we call haplotypes, and there are two, H1 and H2. Those are two forms in which all these variations of the gene tau can present. And people that have corticobasal degeneration, what we found is that, as in PSP, 92% of the patients have this H1 haplotype. Very few have the H2, but 77% of the healthy people also have this. So this alone doesn't help. There was a GWAS studies to try to look more into the genes, but there were only 144 patients that we had brains to look into it versus 1,000 brains of people with PSP and 1,000 clinical cases diagnosed accurately that would allow us to make conclusions. So the conclusions in this disease will be more limited because we have less amount of information. Still, we were able to confirm in those 154 that this tau gene gives susceptibility. That's as much as we can say. It gives susceptibility for someone having the disease. We also know that there is inflammation and there is oxidative injury. It's as if when our brain gets older, there is not enough scavengers that clean part of the oxidation that exists normally, and then that causes part of the disease. And why is this important? Because maybe antioxidants could be a helpful medication. Why is it important that we know about inflammation? Because maybe anti-inflammatories can be helpful. But is inflammation truly what causes the disease, or is it a secondary to death of cells? We don't know that. And so, because we don't know if it's a cause or a defense, we cannot treat, right? We need to know the exact thing before we go into human trials and before we can tell you this is what you need to do, because we don't want to cause damage. We want to help. So we hypothesize that yes, having that H1 haplotype, modifying genes, and perhaps some environmental factors may lead to these neurons that get these clutter cells with tau. And we don't know the role of inflammation. Is it protective or is it contributing to the development of the disease? But that is key for the biological therapies. But we do have one good thing, though, that there are animal models. There are animal models of tau that here you see a little mice that initially had the normal movements, now starts to have an abnormal way. And later on, it's going to be worse. So the balance is not as good. These models that are animal models can help us find ways of understanding treatments that can make tau disappear, tau to be disaggregated. This is a normal one. This is an abnormal one, and you can see as the disease progresses in the mice, they have more and more difficulty. This is more difficulty, and here is even more difficulty. They also have dystonia. So they're not only slow, they're not only having postural instability, but they also have dystonia. They even have some eye problems. So it's a little bit of a model, not a perfect one, but at least something that would allow us to help out. And here that led to go with the first trial that NIH moved forward, that was use of lithium in people that had PSP and have corticobasal syndrome. Happens to be that this drug was not tolerated and the study had to be stopped. But it was based on that animal model. And so I think that it's important for us to know. There is currently another study that is mostly on PSP, but it was started, and I think at UCSF as well, in corticobasal syndrome patients. And this study is still ongoing. So we don't know. So at least there are some treatments that people are moving forward, even if we don't know the ins and outs. And certainly we do have palliative treatments. If someone has dystonia, we can use botulinum toxin. If there is this problems with speech, with swallow, we can use rehab, speech therapy. If there is myoclonus, there are drugs for that. If there are gait and balance problems, there is physical therapy, occupational therapy. And there is always what you have here, that is layman organizations that can give patient and caregiver support that is so relevant and allow you to meet other people that have the disease, and you don't feel that you're alone in the world having to fight against a disease that is not frequent. So, yes, we don't diagnose the disease well. We are diagnosing less than the people that have the disease. We still don't have a marker to make the diagnosis, but we're searching on new ways on diagnosing the disease, putting forward new criteria that we need to validate and hopefully will help move the field forward. And if we are making errors, hopefully we'll be able to get corrected by learning on what the errors are. And I think that as you, I want more research. So write to your congressman and let them know that we need more research. That's what you can do. Thank you. So now I'm ready for questions. I'm also ready to show you a few things. I want to show you that I like this for balance. I think weighted walkers are very good. If you have an aluminum walker, please don't use it. That makes me very nervous. It's not good. Speech and swallow is very important, as I mentioned. All right, first question. Corticobasal degenerations and immobility. What exactly this means? Does it mean unable to walk or unable to make effective, purposeful movements of any kind? So this is a very good question because I think it goes into both. We may have difficulties in making the right movement because the leg may go into doing movements that we don't want them to be made, and that's what leads to the falls. So the immobility is mostly the result of difficulty making the right movement, and that with the jerking of the leg may lead as well to falls. So the slowness with the freezing, with the difficulty controlling the movement, all that leads to immobility. Second question. Corticobasal degeneration? Yes.
Will we eventually be completely paralyzed?
No, this is not a disease of paralysis, and I'm glad you're asking that question. This is not a paralysis disease. The strength is always there, always. The difficulty is controlling the movement. As our patient said, the difficulty is the control of the movement, but the strength is always there. There is never paralysis. But there is there is dystonia, and so the movement is more difficult, but that doesn't mean that you can move. Corticobasal degeneration and sensory loss. Is it due to damage to somatosensory cortex? What types of degrees of sensory deficits are seen? So the problem is really that the lesions are in the brain, in brain areas that that control attention. It's not that you cannot see, is that you have a neglect, you kind of ignore in some ways one side when two stimuli are occurring at the same time. But if you have only one stimuli, then there is no problem. So it's not that there is no sensation, it's not that there is no vision on one side. The vision is there. You may have seen some people that actually, I think this is an important thing to say. Sometimes patients get to look at one side and the family member is on the other side, just the side where they neglect. And so the family member doesn't understand why is it that they don't move their head. Why aren't they looking at them? Are they ignoring them? No, you just happen to be standing on the wrong side. So you just move to the side where you're gonna get more attention. So this is important. It's not a deficit that you cannot see. You just need to know that there are two stimuli and only one you're responding to. So I guess that's that. Would you recommend oculomotor testing early if I have corticobasal degeneration? The saccades. Well, it's a good question. We do that clinically, so you need to make sure that your neurologist does that, because as you saw, I did it clinically. So the oculomotor testing should always be part of your examination when you have an atypical Parkinsonian disorder, certainly. Please, what supplements can we take to improve this condition? Well, we don't know. I mean, that's the simple answer. So I can tell you that in PSP, that is another tauopathy, there are some studies that suggest that coenzyme Q10 is helpful. However, 1200 milligrams a day, 400 3 times a day. Coenzyme Q10, as you know, is over the counter, so it's something that you can take, but it's expensive, and we don't know. So I always say to my patient, if you really don't have the money and we don't know, I don't know if you should be doing this, because that's kind of putting your life in a, you're kind of trying to help, but we don't know if you're helping, and then you're getting less resources for your own illness. So I'm not sure that's the right way to go. If money is not an issue, well, I would take it because it doesn't have side effects. Coenzyme Q10. 1200 milligrams, 400 milligram per dose, 3 times a day. That doesn't help in Parkinson's, though. There were 2 studies in Parkinson's, and none of the 2 studies, the first one showed benefit, the second one showed no benefit at all, and we stopped the trial. So as I say that in PSP, it seems like it works, I want to say that a major multi-center study that was for Parkinson's disease, that is true, it's a different protein that aggregates in the brain, but in Parkinson's, it didn't work out. So just for you to be aware that we can take many things, but the question is, will they help? If they don't have side effects, I don't have too many problems with it. But if they do, certainly not what I would recommend. It's not being studied. So that's like magnesium, and I can give you a list of multiple things that each person may have its favorite, but there's not really any study that shows benefit. None. No Exelon patches help with thought and retrieval processing in the brain. That is absolutely true. Exelon doesn't help. Doesn't help in this disease. So the mechanisms are different than in Lewy body disease. For Lewy body disease, Exelon patches are wonderful, but not for this disease. So I wouldn't try it. In fact, we did a study with PSP patients, and they got worse with this, similar to Exelon patches. It was something else, but it's the same class of drug. So I would not recommend that. You differentiated between, let me see here. Oh, you differentiated between Alzheimer's and atypical Parkinsonism. In Alzheimer's, information, memory, and understanding are gone, unlike in atypical Parkinsonism. If information and memory problems are primarily retrieval, but understanding is gone.
Oh, I didn't finish that. So then where does that, I mean, my husband, the information can be there,
Yes, yes.
but understanding's gone.
No, understanding is not gone.
No, but in my husband's case, understanding is gone.
Ah,
It's more like Alzheimer's,
it is more like Alzheimer's, yes.
even if the retrieval, even if he can remember if he's prompted.
Well, but if how can you prompt if understanding is not there?
Ah, um, he can respond to some, I mean, if you, your example you gave earlier about who called,
Right.
you know, if you say who called, that he might understand. If you say, this is for you to eat now, he'll look at it and say, what is this?
Oh, that's a different problem altogether. And I truly can, that it's, yeah, that's a different story. Sorry, but I cannot get into that one. That's a more difficult thing to explain. And it would get us away. So let me go into the more common things. Are there any upcoming clinical studies for corticobasal degeneration? And the answer to that is the current studies are on biological markers. That's the current study. I'm not aware of any on therapeutic trials for the reason that I gave you before. That is, pharmaceutical companies want drugs that would show benefit. And if we include patients that may have different diagnoses, then we will not have benefits because one of them may respond to the drug that is intended to, but the other may not respond to that drug because it has a different disease. Let's say that the drug is very good. And so let's say that we want to treat corticobasal degeneration and we have 50% with corticobasal degeneration and we have a third with Alzheimer's and another third with something else. So what results are we going to get? The drug has to be more than a miracle to get results that are positive. So that is very difficult. So there's really a lot of difficulties in going with therapeutic trials when we don't have an accurate diagnosis. So that's why improving diagnostic criteria and finding a biological marker would allow us to get to that step that you all want and we do want as well. That is, identify me with the disease now, and so I can be part of a study. I can get a knowledge of what is going to happen to me, so on and so forth.
There's a study with Dr. Ash, A-S-A, in San Francisco. That's going on now.
On,
Our disease.
but on what?
Exactly, I don't know really, but she talked to me about it, and there was a lot of MRIs and stuff like that, which I'm not in favor of. And there is a study going on now.
Well, that she's saying that there is a study going on in which there are MRIs and she's aware of. That study is a biological marker study. That's a study in which we're trying to find out is by MRIs, by blood, by urine, we can find out how we can diagnose a disease more accurately. But there is no therapeutic trials, that's what I meant, no drugs that I'm aware of. Is there any difference in life expectancy between PSP, corticobasal degeneration, multiple system atrophy, and dementia with Lewy bodies? Yes, there is. And there is as well depending on the form of presentations. So if your presentation is with dementia, the prognosis is less good, particularly in dementia with Lewy bodies when there is not a very good response to medication. But I've seen wonderful results, I have to say, with excellent patch in that disease in particular. But in corticobasal degeneration, it also depends on how you present as well. If you present with dementia, the prognosis is worse than otherwise.
We have time for one more question.
All right. Do you want to choose it? With corticobasal degeneration, do patients have a type of blindness, difficulty seeing perhaps without being aware of it? And that's kind of what I tried to explain before. There is no blindness, not at all. There is, yes, neglect. There is not ignorance of that aside. Okay, I think that I thank you for all your questions. I'm sorry for all those I couldn't answer. And I hope for the best. I hope you can see some drugs that would really help prognosis.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.